Imagine a perfectly healthy child laughing, learning, rowing, and suddenly tiny white patches appear on their skin, followed by unexpected seizure. What if I told you that behind these small signs lie a rare genetic condition that silently affect the brain, kidney, heart, and even behavior? Today we are diving deep into tuberous sclerosis complex, one of the most fascinating and challenging disorder in neurology. So, today we will discuss in detail about tuberous sclerosis, how to diagnose, how to manage, and what is which drug, with dosage. We can explain all the detail about tuberous sclerosis, and you will be able to correct any MCQs and any exam after complete listening of this lecture. So, let's start our presentation. Tuberous sclerosis complex, defined as it is a multi-system disease characterized by autosomal dominant inheritance and variable expressivity. Prevalence is 1 in 6,000 to 10,000 newborn. Spontaneous pathogenic variant occur in 65% of cases, caused by mutation in tuberous sclerosis 1 or tuberous sclerosis 2 gene. Clinical presentation, it's a wide clinical spectrum, may involve skin, brain, eye, kidney, lungs, and heart. Neurodevelopmental issue such as intellectual disability, autism, and seizures. Cutaneous lesion such as hypomelanotic macule, angiofibroma, and Sjogren patches. Multiple organ hematomas are characteristic. The hallmark of tuberous sclerosis is the involvement of CNS, central nervous system. Cortical tuber, which formed before birth, and subependymal nodule are common. Subependymal nodule are lesions found on the wall of lateral ventricle where it undergo calcification and project into ventricles producing candle dripping appearance. Remember this, candle dripping appearance. It's very important for MCQ's point of view. 5 to 10% may develop subependymal giant cell astrocytoma. SIGA may obstruct CSF flow causing hydrocephalus. Frequent cause of refractory epilepsy in children, brain MRI every 1 to 3 years and asymptomatic patient. We will do brain MRI every 1 to 3 years and asymptomatic patient and diagnose case of tuberous sclerosis. Okay, this picture taken from Nielsen 22nd edition Nielsen textbook of pediatrics. The first is a CT scan brain in which there is a subependymal calcification. Let me mark this. Okay, so this is the subependymal calcification. The second image is MRI brain, which demonstrate subependymal nodule. Tuberous sclerosis complex and infantile spasm. Tuberous sclerosis can present in infancy as infantile spasm. EEG may show hypsarrhythmia, but infantile spasm can also occur without hypsarrhythmia. You can see in this EEG, there is no pattern you can appreciate. So there is hypsarrhythmia. Seizure and tuberous sclerosis are often difficult to control. Later onset seizure may evolve into focal onset seizure or generalized myoclonic seizure. First line treatment, vigabatrin is the treatment of choice. If not controlled, then second is ACTH and prednisolone can be used as alternative. Skin involvement in tuberous sclerosis, hypomelanotic macule, ash leaf spot. At least three should be present for diagnosis of tuberous sclerosis. Facial angiofibroma, adenoma, sebaceum, 4 and 6 years of age, and topical rapamycin is the treatment for adenoma sebaceum. Sjogren patches, connective tissue nevi, lumbosacral region, present in lumbosacral region. Ungual fibroma and forehead plaque. Renal angiomyolipoma, common and oftenly bilateral in tuberous sclerosis. Renal cyst, polycystic kidney disease, especially with TCA2 PKD1 mutation. Risk of bleeding from large angiomyolipoma. Risk of renal cell carcinoma increase. Ultrasound or MRI of abdomen every 1 to 3 years. We will do ultrasound and MRI every 1 to 3 years. This is also very important for exam point of view and also clinical point of view. Around 50% children have rhabdomyoma and detected by echo and the fetus. Eye involvement contain retinal hematomas, usual asymptomatic but helpful in diagnosis. A routine ophthalmological exam recommended. Okay, so this is the signs of tuberous sclerosis, hypomelanotic macule, uh, and this is facial angiofibroma. The second one in the picture B, this is called facial angiofibroma, and in C, this is Sjegren patches. This is periingual fibroma in a patient with tuberous sclerosis, and a mulberry lesion involving the superior part of the optic nerve in the patient with tuberous sclerosis. Diagnostic criteria of tuberous sclerosis. Diagnosis can be made if at least two major or one major plus more than two minor criteria fulfilled. Genetic testing confirmed pathogenic mutation in TCS1 or TCC2 genes. Major feature of tuberous sclerosis: cortical dysplasia, subependymal nodule, subependymal giant cell astrocytoma, facial angiofibroma, angular fibroma, hypomelanotic macule, Sjegren patch, multiple retinal nodular hematoma, cardiac rhabdomyoma and renal angiomyolipoma, pulmonary lymphangioliomyocytosis. Minor feature of tuberous sclerosis complex is dental enamel pits more than 3, intraoral fibroma more than 2, retinal achromic patch, confetti skin lesion, non-renal hematomas, multiple renal cyst. What investigation we will do if we suspect tuberous sclerosis? MRI brain for tubers, nodule, and SIGA. Every 1 to 3 years, we can do MRI brain in these patients. Renal ultrasound or MRI for angiomyolipoma and cyst every 1 to 3 years. This also can be done every 1 to 3 years. EEG if seizure present are to detect subclinical seizures, especially infantile spasm. Echocardiography and NPEN for rhabdomyomas, and echo can be done every 1 to 3 years. Ophthalmological evaluation annually, and pulmonary function test and HRCT in adult, especially women, every 5 to 10 years. Follow-up and management. Annual scan, eye and neurological evaluation, brain MRI and renal imaging every 1 to 3 years. EEG if history of seizure or behavior changes noted. Consider mTOR inhibitor such as sirolimus, everolimus for SIGA or AMLs. Surgical treatment for SIGA causing hydrocephalus. Multidisciplinary care, neurologist, nephrologist, and dermatologist should be involved.